Hello, I'm Dr. Wayne Rosen, and I'm a colon and rectal surgeon and clinical assistant professor of surgery at the University of Calgary in Alberta, Canada. Welcome back to part 3 of this 4-part lecture series on the shortcomings of EBM and why it just doesn't work. I call this lecture the Fallacy of Quantification. Now, before we go any further, let me summarize where we've been. In part 1, I suggested that EBM is analogous to the geocentric conception of the universe, and I discussed and illustrated that evidence-based medicine has become the dominant paradigm for how to teach, learn, and practice medicine. In part 2, I discussed some of the examples of clinical studies that have anomalous and inconsistent results. First, the chlorhexidine-povidone iodine study for wound infection. Second, the fistula plug treatment for fistula in ano. And third, the comparison of 2 studies evaluating CT colonography and optical colonoscopy for colon cancer screening. And I suggested that perhaps there is a basic methodological problem, a misconception at the heart of EBM, which gives rise to such anomalous results. Now, no doubt you're wondering, okay, what is this fundamental misconception that I keep alluding to? What is the mistaken assumption at the heart of EBM which leads to all these discrepant results? Well, in order to illustrate this, consider what we do when we study a disease or treatment. We start by considering how we can measure the disorder, and in order to measure it, we quantify it. That is, we give the condition and aspects of treatment discrete numerical values. Let me give you an example in an area with which I'm quite familiar, fecal incontinence. If you want to study fecal incontinence, at least within the EBM framework, we need to provide an ostensibly objective standard which allows for comparison. Here is an example of a tool or instrument which is used to measure incontinence. This is known as the Wexner Incontinence Score. It takes a complex phenomenon like incontinence and breaks it down into its major constituents, allowing us to measure it. You can see here that we take into consideration a number of factors such as control of gas, liquid, and solid stools, whether the patient needs to wear a pad, and whether it impacts a person's life or not. All very reasonable aspects to consider when assessing the severity of a person's incontinence. And there is a simple calculus at the bottom which permits us to calculate the incontinence score out of 20. And if we apply this scale to a large number of people with fecal incontinence, we can even assess the so-called reliability and validity of the scale. Often such scales are pronounced validated, which really only means that they appear to measure what they purport to measure. So why do we use instruments like the Wexner Incontinence Scale? Well, for many reasons. First, it appears to permit us to measure the severity of an individual's incontinence. If I have 2 patients with fecal incontinence, and one has a score of 9 and the other a score of 14, I can reasonably conclude that the first patient's incontinence is more severe than the second patient's. Second, it ostensibly allows us to evaluate and compare different interventions. If I have a patient who started off with a score of 5 and after my intervention it becomes a 15, then I appear to have made this patient significantly better. If a different intervention is used and the improvement is only up to 10, then it appears that this second intervention is not as good. In general, the point of the Wexner Incontinence Scale is that it appears to be an objective standard that applies across cultures and locations. Quantification is the process of giving numerical values to qualitative phenomena. Although it is rarely ever mentioned as part of the EBM paradigm, all evidence within EBM must be quantitative. Every single medical study in every single medical journal involves quantifying complex qualitative phenomena to allow for measurement. If it is not quantitative, it is simply not evidence. It will never be published, at least not in a reputable, evidence-based journal. Whether you wish to study the efficacy of a surgical procedure or risks associated with treatment or severity of depression, it all has to be measured numerically. Almost all clinical research involves measuring phenomena that are inherently qualitative, like quality of life, degree of morbidity, burden of disease, efficacy of treatment, patient satisfaction, severity of infection, complications of treatment, drug efficacy and safety, response to treatment, and quality of care provider to patient interaction. There are a few outcomes which may appear to be inherently more quantitative than others, such as lab values, blood pressure, and even the grandfather of all outcomes, duration of survival, but they are not nearly as objective as we initially think, and they are generally floating in a sea of qualitative phenomena. The sine qua non of EBM is the quantification of complex qualitative phenomena in order to allow for measurements. At its core, EBM is a series of statistical methods to analyze quantitative evidence and data. For example, here is a list of some other familiar instruments used in clinical research, and these are not just some of the hundreds or thousands of such tools. These are but a few of the hundreds of thousands of such tools and instruments. I defy anyone to recall a study in the past 20 years which does not involve the quantification of medical phenomena to allow for numerical measurement. Now, just to be clear, this is not my personal view or opinion about clinical research. Although most people who do clinical medical research may not have given this fact much thought, this is what all experts in clinical research will tell you. Medical research is the attempt to measure qualitative phenomena in quantitative terms. Here is a particularly clear description of the process, which I'm going to read. Measurement is the assigning of numbers to observations in order to quantify phenomena. In healthcare, many of these phenomena, such as quality of life, patient adherence, morbidity, and drug efficacy, are abstract concepts known as theoretical constructs. Measurement involves the operationalization of these constructs in defined variables and the development and application of instruments or tests to quantify these variables. In other words, quantification is to clinical research what the alphabet is to writing. You simply cannot proceed with the latter without having the former. Now, there are many reasons why we quantify things in medicine. First, it allows for measurement and mathematical manipulation. It lends a sense of objectivity and provides common standards. It provides a sense of certainty, I would say false certainty, and it lends credibility to a study. That is, a study without numbers is like a picture without words. It's just not taken seriously. There are a number of practical reasons as well. If you want to get money or build or develop anything, you need to show numbers. Or if you want to implement or influence policy or regulation, you also need to show numbers. But in all honesty, I think the main reason why we quantify things now is because we've just gotten used to it. We've just become accustomed to putting numbers to our various experiences. It's worth pointing out that this process of quantification extends well beyond just medical research. It's pervasive in modern life. We quantify the quality of movies, food, schools, and universities. When I work with residents and medical students, I quantify their performance, and not just their skill or knowledge, but many deeply subjective qualities. Here's a section from a performance evaluation used to evaluate my residents. In addition to quantifying their technical skills, etc., you can see that it involves quantifying many subjective characteristics such as honesty, integrity, respect, and empathy. We quantify almost everything. If I were giving this lecture at rounds, you would likely be asked to quantify the quality of my presentation with a form similar to this one. A few years ago, I was listening to the radio in my car and heard an interview with a fellow named Woodson Merrill, who is the chair of the Department of Integrative Medicine at Beth Israel Medical Center, the Albert Einstein School of Medicine. He was talking about his program of integrative medicine and said the following: "There's evidence now that people who live a more connected life live a longer and more fulfilled life." This sort of line usually just washes over us blithely as we're driving our kids around, but stop and take a moment to think about what he has said. He was saying, in effect, that we have quantified connectedness and fulfillment in life. Regardless whether you agree with Dr. Merrill that connectedness leads to a more fulfilled life, I think it's noteworthy that we can purportedly measure these factors in quantitative terms. Okay, so you get the point. So what's wrong with quantification, you might ask? Well, nothing really, so long as you constantly remember that it's not a true representation of the phenomena, and indeed, as long as you remember that in the vast majority of cases, it's a very primitive representation of the phenomena. Quantifying a patient's pain on a scale of 1 to 10 may be very useful for a nurse who is trying to see whether the analgesic he or she administered an hour ago has helped, but it is not an objective standard that transcends time and culture and individual experience. We often forget that pain is not a scale, but rather an experience. We have become so accustomed to quantifying subjective qualitative phenomena that we have forgotten that it is a proxy, and in the vast majority of cases, a very crude proxy of the phenomena we are observing. When you fill out a questionnaire or a survey, say assessing your experience with a product or service, do you ever have the feeling that the answers just don't correspond exactly to your experience, that the options provided don't really match your thoughts or feelings? That feeling you have of uneasiness, of dissatisfaction, is a reflection of the artificiality of the quantitative tool. It is generated by the fact that the questionnaire is shoehorning your responses into a predetermined matrix of discrete possible answers, many of which may not match your actual feelings or thoughts at all. Let me give you a practical example to help illustrate this. Consider what you might say if you were asked to evaluate a meal at a restaurant. You might provide a qualitative narrative about your experience and say something like the following. It is a quaint restaurant with a warm and cozy ambience. The server was friendly and efficient. The soup I ordered was not terribly hot initially, but that was quickly remedied when I mentioned it. It was otherwise very tasty. The main course, a Thai green curry, was somewhat spicier than I expected, but was very flavorful and came in a generous portion. The rice was a little overcooked in my opinion. Dessert was delicious though, and the decaf espresso was excellent. Price-wise, it was not cheap, but well worth it. The chef came out and greeted me personally. Now imagine you are asked to evaluate the same meal using this quantitative questionnaire on a scale of 1 to 10. No doubt you can see what I'm getting at. Your quantitative evaluation is a far cry from your qualitative narrative. It is true that people may be interested in the aggregate numerical data provided by many people who rate the restaurant according to this questionnaire, but we should not confuse those numbers on a scale of 1 to 10 with the ambience of the restaurant, the smile on the waiter, and the great coffee. The effects of quantifying medical phenomena are profound. Quantification is like a cattle chute which forces a widely spread herd of cattle into a single row for easy processing. It forces an artificial structure onto amorphous phenomena. It is frequently misleading and does not do justice to the phenomena. It distorts and oversimplifies complex phenomena. It leads to a loss of credibility for non-quantified research. Things that are not easily quantified are often left out of research, and it creates a facade, a veneer of objectivity, and a false sense of confidence, while glossing over the inherent subjectivity of almost all clinical research. When you pull aside the curtain of EBM, it is clear that it is nowhere near as objective as it purports to be. The process of quantifying complex medical phenomena is a false god, and it has distorted and contaminated almost every aspect of clinical research. Just because we give complex phenomena like fecal incontinence a fancy numerical value does not make it objective. In fact, in most cases it's utter nonsense. It's like quantifying connectedness and fulfillment in life. And that is why we frequently get such anomalous and peculiar results. Attempts to quantify severity of illness, burden of disease, degree of disability, severity of complications, extent of depression, quality of life or experience, response to treatment, surgical techniques, etc., are all fraught with uncertainty and inexactness. Quantification of clinical research may give us a vague outline of the phenomena, but it does not come close to reproducing the original. In many cases, it is as crude and inexact as trying to measure the thickness of a piece of paper with a ruler. So this is what I mean when I refer to the underlying misconception at the heart of EBM. EBM is premised on a notion of quantitative evidence, that is, numerical evidence which objectively measures the medical phenomena we are trying to evaluate. And the truth of the matter is that this approach to medical disease profoundly distorts and misrepresents medical phenomena. It is what I call the fallacy of quantification. When you really think about it, at its heart, EBM is a narrative of what constitutes good evidence. That is what the hierarchy of evidence is all about. But it presumes that all evidence must be quantitative. There is never any discussion of this. Qualitative evidence is never even considered. As I said above, there is nothing really bad about the process of quantification, as long as you constantly remember that it is an inexact and primitive substitute for the real phenomena. As long as you remember that in most cases the process of quantification cuts up the phenomena with the same fineness that a chainsaw slices a strawberry. Now, if you have watched this presentation from the start, that is from part 1, you will recall that I told you my conclusion right at the outset. I said that I'm firmly of the belief that EBM is a misguided and ineffectual enterprise, and that advances and improvements in medical care over the past several decades have not occurred because of EBM, but rather in spite of it. As I said then, I really believe this, and I hope you are beginning to understand now. Given the distortion and misrepresentation inherent in the process of quantification, it is no wonder that we get such bizarre and anomalous research results. and it is no wonder that most physicians harbor a deep but often unarticulated reservation about the entire EBM enterprise. In fact, when you really think about it, it is remarkable that we have made any progress in patient care at all, and that is why I believe that advances and improvements in medical care over the past several decades have not occurred because of EBM, but rather in spite of it. Now, make no mistake, I do believe we have made significant advances in medical care. I do believe that surgical procedures have improved, that we have better chemotherapy, that cardiac stents work, and that DVT prophylaxis saves lives. I just don't think it's because of EBM or anything related to it. I think it's because when it comes to caring for patients, common sense tends to prevail and physicians ignore most of the nonsensical research. If you ask a bunch of physicians, even those at universities, whether they practice EBM, you'll be surprised by their responses. Nobody ever says, "Oh, yes, I do." Instead, they say things like, "I try to, but there's not a lot of good evidence in my area," or, "Well, sort of, but it doesn't always apply to my patient population," or, "Well, it's tough because patients are very different." I believe that what physicians are really saying in these statements is that EBM just doesn't really reflect the real world of medical practice, and that it just doesn't work. So to be clear, I do believe that we have made improvements in patient care, but I am sure that it is in spite of the evidence-based medical movement, and not because of it. Now, if you are puzzled and perhaps a little confused because the argument I've made seems a little bit compelling, but it's hard to reconcile with your own notions of research and scientific advancement, then I suggest you listen to the final lecture, Part 4, where I will address many questions and objections to my arguments. Thank you.